I do listen to my patients, and I do take the time to ask them about their lives, not just carve out a piece of them for appointment 8:45. The other part of my team is Vanessa Marcel, who is my genetic counselor. Now, most breast cancer is not genetic. And this is a myth that's in the community. A lot of women are like, well, there's nobody in my family with breast cancer, so why do I need to get a mammogram? And let's go back to mammography for a second. Everybody always says to me, this was so clearly invented by a guy, right? And I'm like, yes, it was invented by a guy. They're like, Candace, isn't there anything that's better? Isn't there an easier way than having to like put them on the shelf and get them smushed? And I'm like, you know, if there were, I promise you'll be the first to know. But this is truly the best screening tool we have. So over the years, people have sent me various jokes about mammography. And my two personal favorites are how to get ready for your mammogram. It says, 1, go to the refrigerator and open and close it on your breast multiple times. I like that one. And the second one is, lay down in your driveway and have somebody ride over your breast back and forth. And the thing is that, is mammography the most comfortable thing in the world? No. Is it your top 10 things of things you want to do? No. But you know what? It saves lives. And that's a big deal, okay? Because mammography, as uncomfortable, as weird, as oh my God, do I really have to put them up there? And then I have patients who are size A, and they're like, I don't have anything to put up there. You know, it really is the best screening tool we have, and it's crucial that you have it every year. Now, I mentioned about the genetic piece, and I just introduced Vanessa because there is a smaller percentage of breast cancers that are genetic. Now, for those women, we need to identify them, and part of what we're going to build at Good Samaritan Hospital is a high-risk assessment clinic, which means that if you have patients, if you in your family have a history of breast cancer, you may or may not be someone who needs to talk to her about whether your family carries a mutation for breast cancer. Because if you carry a mutation, then your risk of developing breast cancer is very, very high. And we need to do something about it. Now, it's not one of these tests that you do and then you're like, great, now I know I'm going to get breast cancer and I'm just going to be walking around terrified for the next 30 years. We can do something about it. There are options. And that's the point, is to identify those people. If you know in your own family there's a history of breast or ovarian, because breast and ovarian are linked, then you may need to be seen by Vanessa. But most breast cancer is not genetic. Most breast cancer just pops up. And I can't tell you how many times I get but how can I have this? Nobody in my family has this. I get it all the time. So it's crucial for you and the women in your life that you care about that they get a mammogram every year, starting at age 40. Now that's a big controversy, right? We've all seen in the news, you know, mammography. Every time mammography gets settled, somebody else writes another thing about how it's not cost effective and we shouldn't be doing it. And well, I will tell you the facts that have been around for 30 years or 20 years. That in the 40 to 49 age group, doing yearly mammography reduces the breast cancer death rate by 25%. Boom. Now, no one will ever argue with me on this one, but this is where the change in the recommendations came from. Well, you have to do so many mammograms in this age group to find the cancer. Well, guess what? If you're the one, you don't really care how many you have to do, okay? And the point is that we can't approach breast cancer screening like we approach buying lawnmowers or whatever. I mean, we're talking about something that saves women's lives, proof positive. We can't look at it as, well, we're going to spend this much. I mean, it's not like the test itself is not an expensive test. It's quick, it's non-invasive, and it's crucial. So I would say when people say to me, well, what do you think? Do I really need to get one? Yeah, you really need to get one. And starting at age 40 and on, you need to get one. Because this is the best screening tool we have. Now, are there problems with mammography? Sure. In women who are very young or women who have dense breasts, sometimes we don't pick up things, but it is the best thing we have. And it is very important to understand that you need to get it every year. The answer is it depends on what that means. Sometimes when a mammogram is abnormal, it means that the radiologist sees something and they're not sure if it's real or not. So they call you back and they do additional views where they compress you even more, which is like, oh my God, but yes, to see if it's real. If it persists, then they may do an ultrasound, because things that show up on mammogram frequently show up on ultrasound. So it's a whole spectrum. I would say that most of the time when someone is told they have an abnormal mammogram, it doesn't mean they have breast cancer. But a small percentage of the time, that will be the first thing. In other words, that will be the first finding, which is why mammography is so crucial, which is also why it's so difficult for many women to believe they have breast cancer, because they say, I feel fine. There's nothing wrong with me, which is the whole point, right? The whole point is to catch it before it goes anywhere, and that's what mammography is about. So in answering your question, an abnormal mammogram is a very large spectrum of things. It can be everything from, we need to do additional pictures because we saw some tissue that we think is nothing. We just need to get a couple of more angles to prove that it's nothing, to, yes, there is something suspicious here. We need to do a biopsy. That's an abnormal mammogram. Okay, that's a very good question, because obviously, surgery, as much as it's a normal thing for me, for most people is someplace that they don't want to be, and I get it. So I do see women once a year for their routine exam, and the way that I've worked that out is they can make their appointment to have their mammogram done at Good Samaritan Hospital, and I can see them the same day. Now, if radiology can, they will read it the same day. If not, I will look at it, and I'm not a radiologist, but I can I get an idea if a mammogram looks normal or not. And so I have a lot of the patients who have followed me from Queens, some of them are cancer patients, but some of them are not. Some of them are women who I just see once a year for their checkup. So the answer to your question is yes, and what I find is, because the anxiety is so high, that if they get their mammogram, they come back to see me, I can look at it. And usually I can call Dr. Bobroff and say, Lou, is it okay? And he'll say, yeah, it's okay. And then I can tell the patient that. Or, no, you need to go back and do an ultrasound to try and get everything done at once so that the patient can go home, you can go home relaxed. Because I know from doing this for a long time that women, before they get their mammogram, sometimes they don't sleep, they have stomach aches, they need somebody to go with them, and when they're done and they're told that everything's okay, they go and they have a drink. You know? Somebody said to me, you know, you should probably have some alcohol in your office. I'm like, no, I don't really think it's a good idea. When my patients need surgery, whether it's for cancer or a biopsy or whatever, I am a little unusual as a surgeon. And probably you figured that out already, okay? Because surgeons are not known for their warmth, okay? And I know that the patient is absolutely terrified when they're in the operating room, because that's a very natural place for me, but it's not natural for anybody else. And so I am very adamant about not having the patient put to sleep until I am standing next to her. Okay? And when I first started, the anesthesiologist would say, oh, you can go scrub, I'm going to put her to sleep. I'm like, you are not putting her to sleep. You are not taking her in the room. You are not doing anything until I see her in the pre-op holding area, and I can talk to her, and I can reassure her a little bit, and she knows that I am here. Okay? And I have a little thing that I do with all my cancer patients is I give them all a little hat. Okay, which is something that I started doing a few years ago, and I order it from greenscrubs.com, and I always bring out a choice of 2 for patients, and you know, there are a whole bunch of them. There are, you know, cats, dogs, golf, basketball, ships, whatever, and you know, and it's a little thing, but it makes a big difference. So I make sure that's done, and then I'll go change to my scrubs, and I'll make sure that the patient does not get to the room until I'm ready for her to be there. Because lying on an operating room table is terrifying. And I'm the only person she knows. She doesn't know the anesthesiologist. She doesn't know the nurses in the operating room. I'm the only person she knows. So I want to make sure that I'm standing there and talking about holistic. I'm a big believer in touch therapy, which is why I'm so huggy with all my patients. And so I will hold my patient's hand and stroke her forehead while she's going off to sleep. And I will not leave her side until she is asleep. And I have been there when anesthesiologists who don't know me say, well, I'll give her another bolus. I'm like, she's still awake. I'm not leaving. Okay? And when she's asleep, then I leave. And I scrub and I come back. And the hospital that I was at before here, I had residents. And when I first started there, the residents would go, oh, Dr. Karsif, you can leave, I'll close. I'm like, no, not happening. I said, again, she's going to wake up in a very disoriented state. And there's only one person that she knows, and that's me. And I am not going to have her wake up with a bunch of strangers being totally terrified. It's just not happening. And I will never leave my patients until they are awake, and I escort them to the recovery room. And then a lot of times, anesthesia makes it kind of goofy. Nothing personal against the anesthesiologist. They're not, but the stuff they give does. And so a lot of times patients, when they first wake up, they don't remember things. So I want to make sure that I'm there for a little while, so that because they'll say, you didn't talk to me. I'm like, well, I actually did twice already, but it's okay because you just don't remember. But I will make sure that whatever needs to be communicated, it's communicated, because I'm the one the person knows. And there can't be a more stressful environment than having surgery. And I try and make that process as easy as possible.